Happy Mother's Day to all the mothers out there. Okay. All right.
Just in my defense, I did not study for this quiz.
Well, it's just an interesting quiz. I'm making a proposal that I hope everyone will appreciate. That and of course, obviously, it revolves around healthcare epidemiology. And my title today, which you can't see because I didn't click on it yet. There you go. Nutrition, health equity, COVID-19, and cardiovascular mortality. And so you might be wondering, what does this have to do with it? So that's the beginning of the quiz. Any idea? And can't you unmute some of the audience and get participants?
Yeah, I can. Let me see. Can we mute just I guess a few people at least?
Or let's look in the chat. The question is, what is this?
Okay.
Now, what does it have to do with cardiology? Yeah. So
they look like really huge platelets is what they look like to me. I have no idea. Anyone in the chat, if they want to respond in the chat, anyone have any idea what that is? Help me out. Be my lifeline.
So I've got the chat. So hopefully people, I don't know if you can actually see the chat, but someone.
Fatty nodules.
Okay, at least somebody out there gave it a shot. Okay. So it's a little bit unfair if you're not people. So they're not blood clots, but good try. All right. So without holding people up to, but now you're into it. So there's going to be a few of these. This one is actually smallpox. Okay.
Ooh, okay.
And the reason you're not familiar with it is actually the reason that I put it in the lecture. Believe it or not, the fact that nobody recognized this is going to make my point. So thank you for okay. Beautiful little virus, sort of coming in like a diplococcus, So why is this cardiologist talking about smallpox? Because I'm really talking about ethnic disparities and the fact that we have such horrific healthcare disparities. It's not just black and white. I'm obviously grew up on the south side of Chicago, so I'm going to focus on that, but it's socioeconomic. So you could take, for those of you who live in Appalachia, the Eastern Kentucky, you could just take everything I say about race and replace it with social determinants such as poverty, because it's really much the same. So anyway, this was about Boston. It was really popularized by Ben Franklin because he knew how to publish and he had the respect of everyone. And he started out as an anti-vaxxer, and he got converted after his 4-year-old son got smallpox and died. And so the idea is that, vaccination or inoculation was something that no one had really popularized, and people were dying of smallpox, and more blacks were dying than whites. Why? Really because of the way it spread. It was local spread, and if you were high population concentration, you didn't have a big house where you spread out from someone who was sick, so you would end up with this disease. And it was really difficult in terms of healthcare because it was the 18th century and there wasn't a lot of supportive stuff that you could do. And people were left to either get better or not on their own. And so, as it turns out, there was not a cure, but prevention that was brought to the United States by a slave who was captured in West Africa. You're seeing a picture of him. And he became famous because there actually was smallpox in West Africa. And he knew, as a 6-year-old kid, he understood that if you took took a sharp object, punctured one of these smallpox pox, and took some of the contents and injected it into somebody else, they can get the disease or die, or they would become immune. And the number of people who became immune was way more than the number that died from it. So he popularized it, and he basically saved the lives of a massive number of Bostonians. And if you looked over time, once Onesimus was his name, once they started to popularize or democratize this inoculation process, you could see the death rate just go down further and further. And now, of course, you get to the point where you could show this to a room full of 5,000 people and nobody knows what it is. Unless you were an infectious disease doctor, there's no reason that you would know smallpox. And that is the success of curing disease and eliminating disease. And it's saved a lot of lives, but particularly a huge black-white disparity disappeared. Okay, question number 2. Anybody? I'm going to open up the chat box again. Anybody recognize this?
Is that the Suez Canal?
Oh, historically, you were so close. Geographically, not at all, but historically, so close.
Yes.
Anyone? Beautiful picture. Someone type it in. You can do this. Anyone? Simona? Ben Wu? Barbara? All right. Oh, there you go. Margaret, thank you. Panama Canal. Absolutely. So why is this cardiologist talking about the Panama Canal? Very good. You actually have the Panamanian flag over there. So the reason that Suez wasn't 100% wrong is because the digging of the Suez Canal and the way that changed commerce, connecting bodies of water so that ships could pass from east to west, it really made a big difference. And so people wanted to do this in the Americas. All the goods from China wouldn't have to go around the bottom of South America. They'd actually be able to go to the European side pretty quickly if they just could cut a hole in Panama or somewhere else. And so there were many different areas, including Northwest Colombia, that people thought that they could do this. But the narrowest turns out to be very near Panama City. And the French were really, because of their experience with the Suez Canal, they thought they could do this. And they were digging the trenches. And this is what it looked like. Now, you have to think of it. This is the late 1800s, okay? And the emancipation of slaves a little earlier in the Caribbean than it was in the United States, but still, you had many Black people who were poor, who were emancipated. And the idea that you could take a boat from the Caribbean, get down to Panama Canal, make money as a laborer and send it and feed your family sent a lot of people in that direction. Some of them died trying to get there, but many, many people, and you can see on this picture that most of the workers are Black, okay? And every picture that you have trying to clear all of this material to dig this, basically the biggest ditch ever, your people are working day and night. And then the trouble started. And that was when you're digging ditches, you're going to leave water everywhere. And when you leave water everywhere, mosquitoes are going to come. And if you have the wrong type of mosquito, you could actually come up with a large number of people who have no way of protecting themselves, essentially, and they end up with a lot of deaths. In this case, it was yellow fever. This was so bad that the French, as important as this digging this was to east-west commerce, they got to the point where they said, this is not worth the human casualties. So we're going to stop. And so they basically stopped the Black-white differences just by quitting. And so late 1890s, they stopped completely. Well, it turns out this was the mosquito that was so good at spreading this particular disease And this particular virus that it was spreading, it would require that a person was bitten. That particular species of mosquito would then transmit it to the next person that they bite. And so it turns out that the United States in the 1890s actually had a war, the Spanish-American War. And the Spanish-American War was not known for its big battles and combat and mortality like the previous war, the Civil War. And this was actually a war where more people died of yellow fever and malaria than actually from combat. And so it turns out that the United States military had a huge interest in not having soldiers die of these infectious diseases. So they were studying them really hard. And they figured out this mosquito. And so Major Walter Reed, his colleagues, George Dangus, these people actually figured out that mosquito abatement could stop this from happening. So you take all of the ditches and all the water and you put oil on top of it. You do everything you can so that the mosquitoes can't reproduce and the disease goes away. And so that's what happened. You know the rest of the story. The United States went back about 10 years after the French gave up. They completed the canal. They rented it from, but the original terms were $100,000, which was reasonable in 1905. In the 1970s, that was a huge mismatch in terms of the amount of money the United States was making over it. And then Jimmy Carter gave it back after in 1976. Which was the right thing to do for the Panamanian people. Anyway, huge black-white disparity eliminated by eliminating the disease. Okay, let's do another one. Anyone? Tell me who this is.
That one I know. I'll let other people guess.
And so which disease am I going to talk about?
Polio.
There you go. Oh, I think it's on the slide. Bad quiz maker. You could take these artistic virus electron scanning EMs and make them look beautiful, but this was not beautiful at all. Unfortunately, because of our racial and socioeconomic structure in this country, this became a huge black-white disparity. And growing up on the south side of Chicago in the 60s, I actually had friends who had polio. And the polio vaccine came out in really the late 50s. By 1964, we had 3 of them. You could take them orally, you could take the injections. But the whole idea is that once people were inoculated, you could knock down this disease. And once you knock down the incidence of the disease, it's really hard for it to spread. Now, the racial side of this one wasn't just getting the disease, which was worse in the Black community because of proximity. People in proximal location to each other is how it spread. This was, fecal oral, so stool, contamination, that sort of stuff, which happens more when you're poor and when you live with a lot of other people. Okay. And so, as it turns out, there was a huge disparity in the incidence, but what was worse was the treatment. That is, there were beautiful, big recovery facilities and iron lungs that were out there for the population, but it was very hard to get treatment for this if you were Black. That's something that everyone knew about because of the president, and leader of the free world, having this disease. So you could argue that more resources should have been poured in, abatement, moving, sanitation, do every public health thing, make sure that there's equal opportunity for sanitation and for recovery. But that was not where we were as a country in the middle of the 20th century. And so more Blacks suffered. Well, how did we stop the Blacks from suffering? Just get rid of the disease. Okay. Anyone want to guess on this one? A little more modern. See, it's a color photo. Two people. I don't see people coming in. Okay. All right. I bet if I show you the next one, you'll see it. Definitely anorexic. Okay. That is HIV. And there you go, Mona. Good job. Okay. This is actually the HIV virus. It's a retrovirus. And this is an amazing thing that hopefully everyone is familiar with. We still have it. It hasn't been eliminated. And it's just hard to imagine that when I was an intern at Grady Hospital, one of my third-year medical students contracted this. And he had all the risk factors, but nobody knew what the disease was. And he ended up having Kaposi sarcoma and dying of pneumonia. And this was a horrific blight that was really spread a lot more in Africa and in the African American population. It's still here. There's still racial disparities, but hard to imagine that this was 6 months later. Same guy. What's the difference? Was treatment, antiretroviral therapy. And I got to know, many of you know that I used to play professional tennis, but I was actually I never maximized my potential because I quit and went to medical school. But my hero back then, of course, in the early 70s was Arthur Ashe. I got to meet him as he was a visiting professor at University of Chicago when I was on faculty there, and had dinner with him and the president of the university, and talked about a lot of things. And during that dinner, as he's waxing philosophically on many things, he's taking like 17 different pills during dinner, and he had to do that multiple times a day. And that was 1993. Imagine what happens when you come up with a therapy that people can do really preventively. There are medications that you can take weeks apart, and you will actually control this disease and get it to the point where, as you see on all the television commercials, that someone has a normal C4 count. That means the immune system is fine, and the virus, even though they have it, is undetectable. And as long as it's staying dormant like that, it can't spread. And so you could look at this huge black-white difference, which is absolutely astounding, and see what happens over time. It's still there, but it's going away. And it's not just and that's because we're able to remove the mortality by getting rid of the disease and managing it. Okay, all right. So anyway, enough with the quizzes. This is, but I do wanted to bring into the idea, and I think you see where I'm going with this. You're all connecting the dots. That this cardiologist is going to say that cardiovascular disease is one of these, but it's not just cardiovascular disease. It's actually COVID-19 as well. And so this is our mortality in the United States. You saw the multiple peaks, you saw the multiple variants, and you also saw that this spike protein, we could take a vote on which virus you think is the prettiest. I'm going to go with smallpox. But the real issue is, what kind of damage did it do on a racial basis? It was horrific, particularly in the beginning. It was particularly difficult for those of us who are African American, some leadership capacity, being told by people in our community that they shouldn't get vaccines, and that this whole thing was something set up to get rid of people of color. Well, the people of color were suffering. No question about it. And a lot of the lessons that we've been talking about this morning were present. That is, people were working manual labor jobs, and they couldn't just stop and start seeing patients at home, which I did. I could hunker down in my condo and essentially do my job as chief of cardiology at Rush and see all the patients remotely, and everybody got their care. But most people in my community didn't have that kind of option. And so you saw numbers like these, that there's a huge black-white differences. And when you look at, it's not just race, it's poverty, And child mortality is still an issue. American Indians were actually worse than African Americans. And so any population that has difficulty with healthcare access suffered more. And so we were analyzing our COVID database at Rush, and we just got scooped. So you don't see our names up here at the New England Journal of Medicine. Oshner actually did a great job, and Ebony Price Haywood put together this data, but her results were essentially exactly the same that we had, and that is that 77% of the people were hospitalized, okay, and 70% of people who died were Black, and that was more than twice the ratio of the population. But if you take race and you put it in the mix statistically with the amount of hypertension, obesity, diabetes, poverty, education, you put all those things in the model, Black means nothing. It was nothing. It wasn't that Black was a risk factor. It was that the Blacks had risk factors. And so it was risk, not race, if you adjust for all of the clinical and sociodemographic characteristics. They got a hazard ratio, for those of you who know what that is, of 0.89. That, if you don't know what that means, that would be 11% protection from being Black. Probably a statistical quirk, but when we analyzed the data at Rush, it was 0.79. It was a 21% protection of Black by being Black, meaning Black actually meant you were more immune to dying from the disease if you didn't have the poverty and the obesity and the diabetes, high cholesterol, and underlying lung disease, et cetera. So the idea is that, yes, we did good with COVID. 3 years later, a lot of people died. A lot of people died unnecessarily. And there were huge Black-white differences, but you're not seeing that now. Why? Really because of the vaccine and all of the things that we did as a society, and healthcare workers and every person who put on a mask contributed to stopping the spread of the disease and somebody dying. And so public health and our healthcare system, and we put all that together, and you could eliminate a huge Black-white difference. Okay, so what I've been talking about now for quite a bit is really about trying to achieve health equity. Racial health equity is a major, socioeconomic. These are major issues that we have to face as a society. So many of you have seen this cartoon before, the difference between equality and equity. But I'm going to give you a couple of variations. Before I give you the one that I really think should be happening, I saw this one, and that is reality. And this is something that we have to be sensitive to, that folks who have in this society have more, and people who have not, usually a hole is dug. And we've got to do better to achieve health equity, because it's in all of our best interest. As long as we are one society, one country, we really need to do better with all of our disease entities. Okay, so here's my proposal in the form of that same cartoon, and that is healthcare justice. Just remove the fence. And so been at this for 30 minutes now, and all I've talked to you about so far is removing a bunch of fences, whether it was 17, 18, 19, or 20th century. When the fence was removed, you may have other problems, but the problems that I've shown you this morning are gone or are so small that we've done so much better. So anyway, I would like to shout out to University of Louisville, people saying, why did you ever leave Rush? And I was really attracted. It wasn't so much about being a department chair or moving up the academic ladder. It was the opportunity to go into a place that was very focused on health equity, coming from the president of the university, she's moved on, but and we have a new president who is equally focused on health equity. And so to be a partner in that, and it just means I have to wear a lot more red than I used to, but it's really a pleasure to be there at University of Louisville. Because all the forms of inequality and injustice in healthcare is the most shocking and inhumane. And so I'm going to talk to you really about the issues around food, because I think of all the things we could do, the one that's so immediate, the low-hanging fruit, no pun intended. Yeah, the pun's always intended, particularly that one. If we say low-hanging fruit and vegetables, we could do so much better with cardiovascular disease and healthcare expenditures. And that would actually leave us more healthcare, more financial resources to do things with housing and neighborhoods and education. We could actually fix a lot of everything else if we fix this one. Okay. And so I've been talking about cardiovascular disease and COVID, polio, and all these things, but it really doesn't matter what you look at. In our society, in the United States, people of color fare worse than their white counterparts, no matter what. And so a lot of our organizations, including 2 weeks ago, the American College of Cardiology, are doing everything we can to try and focus our organizations and our institutions on health equity. So we have the cardinal principles that I'm inheriting, and at the American College of Cardiology, really trying to get everyone to have a fair opportunity to be healthy. I would recommend this website, going to the American College of Cardiology website. You don't have to be a cardiologist. You can look at what we talked about in the Health Equity Summit and defining health inequities, how they exist in cardiology, but as a view of how they exist in the United States completely. And then sort of a roadmap for the things that we can do, creating a better culture, prioritizing it in all of our organizations, aiming at eliminating these disparities so that people have equitable cardiovascular care. Why is it so important? Why start there? Well, you're seeing it on this slide. And that is, we have a horrific amount of cardiovascular disease burden in the United States. It's very expensive, not just in terms of billions of dollars, but in terms of the number of people whose families are destroyed. And then that fifth bullet point, that over half of all African Americans have some form of cardiovascular disease and have a 21% higher cardiovascular mortality. And again, I will, here is a shout out to all of my, if I can get back there, a shout out to all of my cardiology colleagues, starting just when I went into medical school in 1975, but I can't take credit for any of this. Excuse me. But starting in 1975, about the onset of bypass surgery, and stents followed in 1979, and you developed statins and ACE inhibitors for heart failure, and you add one therapy on top of another therapy. And we ended up with about a 70% decrease in cardiovascular mortality. You would think that would have put us at number 2, and we almost got there. But in 2015, it started actually going the other way. I always was going to throw in a little bit about poverty, because here is Eastern Kentucky and West Virginia, and you can see the very dark, the very high amount of cardiovascular mortality, and all cause on the left, heart disease, premature mortality on the right. And so it isn't as much about being Black as it is about having socioeconomic deprivation, starting with the redlining in neighborhoods and poor education, which put you at lower jobs, less vertical transmission of wealth. And so generation after generation ends up suffering the same set of diseases. And one of the things and you could talk about access to care stress, low education and poverty, but unhealthy lifestyle is the thing that's common to most of our people, whether it's Native Americans, eating soul food when you're African American, having really the kinds of high fat, high refined grain diet that you see in poor people throughout the United States. And so you end up with more cardiovascular disease and more blight. So what can we do in the cardiology space to try to make this better? A really nice article put out about 9 months ago in Journal of American Medical Association that talked about every aspect of this, the racism, the sexism, the poverty, and to try to first to get cardiac disease in order, you have to know that it's there. And that's where diagnostic imaging and access to diagnostic imaging is really important. So we continue to have, this is using their outline from Sarkar's article in health inequity and healthcare access, which I'm going to talk about. It's happening across so many communities. And I'm going to give you some concrete examples. There are areas where you just can't get an ambulance. And I was in one of those areas. It was Detroit. Had a wealthy person saw some of the data and gave 60 ambulances to the city of Detroit while I was at Detroit Receiving, running the coronary care unit. We thought it was going to be great that I thought that our, door to balloon time, which many people have heard of, is time the person gets to the emergency room. You find out they're having a heart attack and you get them to the cardiac catheterization lab and open up that artery. Okay. And the door to balloon time was excellent at Detroit Receiving Hospital. The problem was that the onset of symptom to getting to the door and therefore symptom to balloon time was terrible. So anyway, so what did they do with the 60 ambulances? Hardly anything, because they didn't have ambulance drivers. They were taking up collections from the public for a police officer who had 3 kids and couldn't feed them all because they were missing payments. So things are better in Detroit, but you could talk about Flint, Michigan, and the water. There are issues that we shouldn't have as leaders of the free world in our own society, and they do play out, particularly in cardiovascular disease. But when we talk about health access to care being poor in this country, I want to really change the dialogue just a little bit, or change the jargon. That is, we need to improve healthcare, lower costs, better care. That's the so-called triple aim. We've added to Don Berwick's triple aim. Number 4 is actually doing a better job of caring for the healthcare workers. A lot of burnout. We need to address that. But we also have to deal with health inequities. And he wasn't really thinking, you kind of think about what would happen to health equity if Don Berwick's triangle or triple aim was actually taken seriously. They would all improve. Okay, so people talk about access to care, and I'm saying it's actually 3 different things. Number 1, there really is poor access to care. There's longer wait times, fewer providers, less diagnostic tests, and less subspecialty care in our own society. But then there's also access to poorer care. And I always joke, not a joke at all, that I don't get upset when doctors don't follow guidelines unless I wrote them. And I could look back at my career at writing nuclear cardiology guidelines and hypertension and then primary prevention, which I'll talk about today. Primary prevention guidelines, the nutrition section. If people would actually pull up that document from 2019, read section 3.1, and look at the data that underpins those recommendations and change their diet, we could eliminate, heart disease as a major killer of Americans in a couple of weeks. But people are not paying attention to the guidelines. So accessing to poorer care when you have poor provider adherence to guideline-driven management. They're not telling people the right things. Doctors are dying of, and particularly cardiologists are dying of heart disease because they're not following the guidelines that the American College of Cardiology and American Heart Association have published. And then there's accessing care poorly. And that really has to do with are issues of having good advice from a good doctor who's available, but poor adherence, poor lifestyle choices. A lot of that is due to health literacy issues. They're not understanding the importance of hypertension control, for example. But some of it, we really have to look at ourselves, saying this as an African-American man. The idea that African-American men have such poor adherence to therapy, unless the advice comes from an African-American male. Well, I can understand that on the one hand, and I can resonate with it, but we've got to fix that because we just don't have enough African-American men who are going into medicine. That gap is not closing as fast as it should. Okay, so access to care, when people say that, I say, which one are you talking about? Okay, so this is one that I was kind of shocked at. You're seeing the Journal of Cardiovascular Computed Tomography. So I'm using this as an example of diagnostic imaging, but if you wanted to pull it up and for a more full discussion than I'm going to do this morning, you can see the publication reference there. And this was where I asked Michelle Ikram, who was my research assistant back when I was at Rush, and I was complaining with that Rush wouldn't give away the coronary calcium score, which many of you know is a really great screening test. And then all the data came out and said it's better than we thought it was. And then if you have risk factors, you probably should get your calcium scored if you don't know that you have heart disease already. And then it turns out that in our 2019 guidelines, we actually recommended it as a screening tool for people who are not low risk, or even at the high risk. If you're high risk, you don't need it. You need the treatment. But that intermediate zone, which is a lot of people who are above age 40, they really do need this test. The problem is it's not paid for by insurance. And so what can you do? If you have $100 or $200, depending on where you go, you can get this test done. There are places in Chicago, I don't usually name names, but the Advocate system, where it was only $49. And that's a little more accessible, but they're mostly in the suburbs. And so what could you actually do if you have this test recommended, but you don't have the $100 to put down and come to Rush? So I was trying to convince Rush to actually give it away for free, and didn't get very far. And so I said, okay, let's give them data. Rush is a great place. They respond to data. So I was going to ask Michelle to say, we're going to do the pricing of coronary calcium because I think it's putting people at risk. If somebody's a CEO and they're coming to see me because they saw me in some movie, great. They don't have any problem getting a coronary calcium, but the people from the neighborhood where I grew up, this is rent, it's food. $100 is a big deal. Okay, so anyway, she put together the data for all 40 hospitals in the Chicagoland area. And it turns out the average wasn't, that Rush was not out of line. It was actually right in the middle. It cost about $200 on average in our area. But when she gave me the data, I said, Michelle, you're not done. She says, yeah, I'm done. I said, I see 5 hospitals missing. They're all the ones in the neighborhoods that I grew up in. I said, well, first of all, why did you grow up around 5 hospitals? Well, we were really poor and we had to move every year because they wouldn't renew the lease. Okay, fine. But don't dig into my past. Tell me what happened to these hospitals. It was Jackson Park, South Shore, St. Bernard's, Roseland. Where are they? She says, they don't offer it. So we were just stunned that we could actually have a test, which is a core portion of our 2019 prevention guidelines, has a very defined role that needs to be applied to a population to save lives, and it's not available. So we then, being this closet statistician that I am, started taking all the data, and we went into the census data, and what we found is that there was a relationship between poverty rates, household income, life expectancy, population density, and degree of higher education, and whether or not you can get a coronary calcium score. This really shouldn't happen. But when we're writing up the manuscript, you have to do a literature search. We're finding that they're all over. That use of echocardiograms or X-rays in inner city hospitals versus suburban hospitals, they're all very different. So you have access to care issues, and then you have systemic issues that can limit diagnosis. And without an early diagnosis, people are going to suffer. Then you have, of course, all the issues that I mentioned with health literacy, where people do not recognize their symptoms because they don't have the education that lets them know of what it is that they should be looking for and when is it time. If I heard one more time that XYZ disease was worse because the patient came in late presentation, whether it's breast cancer, stroke, or hypertension out of control. These are issues, and I understand that people would rather deny than miss work because they not going to be able to pay their rent. They're living from paycheck to paycheck. So this is the intersection of society and health that makes it really hard. But then we have the biases in optimal care. And this is something that really needs to be addressed. I think many of us are addressing it, such as the American College of Cardiology and University of Louisville, but it would be great if everyone was paying attention to it. That if you look at optimal therapy, such as giving clot-busting medicine for stroke, getting it to the poorer people, the Blacks, Hispanics, and Native Americans, is far less likely. Why is that? That's implicit bias. And the implicit bias is something that everyone can test. You can just go on the implicit bias website from Harvard, and you find out things about yourself that would be very helpful for you to know. And every person who's in healthcare needs to be able to do this, because if you don't gather the information, you'll never recognize it, and then you can't combat it within yourself. And this data has actually been out there for a while. The very famous Serena Williams had a pulmonary embolism after she won Wimbledon and cut her foot in 2011. And so once you've had a DVT and a PE and you almost die, you kind of know what the symptoms are. So then fast forward to 2017, and she is actually 6 years later pregnant, has a baby, and postpartum, she's getting the DVT again. And she recognizes the symptoms and asks them to get an ultrasound. They say, no, you're just fine. You're okay. It's not a problem. Well, then, she gets another pulmonary embolism. Well, that's really inexcusable. But that is unfortunately, and you could, turn it into a television show to get people to recognize that Black women are under listened to. But that's actually been in the literature for a while. This is New England Journal of Medicine 25 years ago, where Keith Shulman actually went to 2 large medical meetings and asked doctors, come on over and take this quiz. And they gave the story of unstable angina with 8 different actors. So Black, white, old, young, male, female. And if you give the 8 actors the exact same story with the exact same hand location, fist clenched over the middle of the so-called Levine sign, and it's clearly unstable angina, and this person needs to go to the cath lab, it turns out that the odds of you getting that recommendation was really high if you were white and male. But if you weren't, the percentages started to go down. And if you were an older white female or Black female, you ended up with a very low rate of cardiac catheterization. So we've had them for a while. The question is, are we going to do anything to address it? And the only way that we can address it is to look from all aspects. And you could talk about it a lot, but we need training. We need to use leverage our electronic health records and do better decision support. We need to figure out how to have a working relationship with our patients that's based on trust. So they're not afraid of us because we look maybe different racially or ethnically or gender-wise. But part of that is having a more diverse healthcare workforce. And then just basic, simple, we should not have huge differences in access to ambulance, one city, one neighborhood, one state versus another. We can do better. So anyway, we can talk about this issue of physician availability. So I have to throw this in. I mentioned it earlier that we have a dearth of Hispanic as well as Black, particularly primary care physicians. And then the number of subspecialists is even less. And the interesting part is that if you look at the life expectancy, you actually see, you could project what would happen to life expectancy if you actually improved, take areas that have dense representation. This was just published a couple of weeks ago. Have dense representation of physicians compared to other areas. And what you see is that if you have enough physicians, your life expectancy in that neighborhood goes up. And so I hope people stare at that and say, every young, underrepresented minority person that you meet, try to talk them into going into medicine because they're going to save a lot of lives. Okay. We still have disparities that are by race that are worse in some states than others. Turns out Kentucky isn't as bad as Illinois, but that's because Kentucky as a whole is, for African-American males, that is not so bad and not so dense. But the west end of Louisville is very dense. And so that's what's making this color as deep as it is. It would be wonderful if, 10, 20 years from now, all of these are flattened out and they're all low rates. They're all in the blue, regardless of race and gender. That's what we need to be looking for. If we don't do something now, this is going to happen. So this was published about 10 months ago, 8 or 9 months ago, from Jim Januzzi at Harvard. And their central illustration has so much data on it, I'm going to actually just summarize it here. What they did was take the disease incidence changes and the 2020 census and project from there what's going to happen in this country. And they say in 2060, there's going to be a dramatic increase in obesity, high cholesterol, that's dyslipidemia, hypertension, and diabetes. And those are going to have their results, which are heart attacks, heart failure, stroke. And all of these are going to decrease in the white population, but increase in racial minorities. So what can we do? Well, we know these are all projections, and this red line going slightly up over time and the blue line being flat or coming down. We don't have to happen. Both lines should be going down, and they should be going down dramatically, because these are 4 things that we can all control. And we don't have to have these 4 things come from the first 4 things. These diseases could be eliminated if you eliminate the risk. Okay, so the time is now. These future increases are just projections. They don't have to happen. We need to have health policies and the efforts of everyone within earshot to change this for the future for all of us. So how do we change it? Well, using the lessons that we've learned. Okay, and so I know this is a long time you were coming here for. I know I was supposed to have a total of 2 hours. I was hoping to do this an hour and a half, and I'll talk for probably another 15 minutes and then open it up for questions. But what I'd like to convince you of, if I haven't already, is that these are things that we really can control. And you can control it through nutrition. We need to change the way that we do food. We need to not have 90% of Americans not meeting the goal of fruits and vegetable consumption. We need to take into account the data that our ethnic disparities are largely due to, and cardiovascular disease are largely due to dietary factors. And so 21% higher more cardiovascular mortality in African Americans. Well, that's related to the fact that 21% of African Americans actually consume enough fruits and vegetables, the lowest of any racial and ethnic group. And so we end up with more obesity, particularly in the African American community, but also in Hispanics. And if you look at obesity by state, and Kentucky is a big one, bigger than Illinois, the number of states that have the greater than 35% of the population being obese, it's the central Midwest and the South, and there's a lot. But if you take only the white population, it doesn't look nearly as bad. But then when you add the Hispanic population, that actually is a lot. And so you end up with more obesity, particularly central obesity and diabetes, high cholesterol, particularly high triglycerides, and not premature death, by the way. You have to, if people have not heard about the Hispanic paradox, you really, every Hispanic person needs to know about it, because they have longer life expectancy than whites. But the disease burden is higher. So if you're Black, you get a short life with risk factors. If you're Hispanic, you get to live long sick. And neither of those are what we're looking for. But anyway, getting back to the obesity, when you look at the United States and obesity in the Black population, very few states, and it's mostly where there aren't a lot of Blacks, almost everywhere, you end up seeing more than 35% of the population being obese. A lot of it has to do with the dietary pattern that was called out by the University of Alabama at Birmingham, the so-called REGARDS study, reasons for geographic and racial differences in stroke. And this is what they showed. That survivorship falling off a cliff over a 5-year period for people at risk is related to the so-called Southern diet. For people who are not sure what that is, that's basically soul food. And so collard greens are great, but if you put ham hocks and neck bones in the collard greens, that's not so great. Yams are good. Candied yams, not so good. Tea is fine. Sweetened tea, not so much. And so when you have a high sodium, high saturated fat, high sugar and refined grain diet, this is what you end up with. Tastes good, but not for long. What do you end up with? Substantially increased risk of heart disease and kidney disease. And I'm going to disease in a few minutes, because it's a particular blight on our ethnic and increases our ethnic disparities, because we are 12% of the population and we're 35% of the dialysis patients. When you look at the association of social and societal factors with hypertension, you come to the conclusion that a lot of it's dietary, that Southern dietary pattern. If you just eliminated that, have Black people eat like other people in this country, which are not good, but you would actually improve substantially the risk, particularly in African-American men. Now, a lot of that has to do with marketing. So here's another study that Michelle and I did. That's my granddaughter in the middle. She was staying with me, and I saw her watching a lot of television. I said, you could actually do something with that. And that is, because every commercial that I saw come up had something unhealthy, something that went against the guidelines that I had so carefully written and gotten approved by the ACC AHA. And so I said, why don't you just write down the foods that you see on each commercial, what type of commercial? And so she did a good job, and Michelle added to it. But between the two of them, they did over 100 commercials. And what we did was grade them. If you saw fruits and vegetables, that would be a plus. If you saw animal products, refined grains, dairy, any kind of something with saturated fat, high sodium, sugar sweetened beverages, each of those would be a -1. And what we saw is that the majority of the food commercials was actually from fast food chains. And on average, they were showing something that had a -3. That is 3 different things that are associated with increased cardiovascular mortality. Okay. And when the individual items did a little better, grocery stores still a little better, home delivery, maybe not as good, but still not as bad as fast food, which was worse than all of them. Okay. So why are we focusing on commercials? Because they work. And when I was a young college student, all of a sudden the cigarette commercials disappeared. Why? Because of legislation recognizing that marketing dangerous things to the population was going to cost the government a massive amount of money in healthcare. That's just simple fact. And that is exactly what folks in the European Union and Canada have recognized. That is, particularly for children, don't do this kind of advertising. But it's not just about children. It is, but it's not totally about them. It's about the fact that marketing affects the poor more than the rich. Why? Because poor people watch more television by a lot than people who are wealthy, probably because the people who are wealthy are working all the time and don't have time to sit in front of a television and watch it for more than 5 hours. So then we have the issue of our junk food industry, tax dollars and subsidies that are making unhealthy food more inexpensive, so it's more accessible to the poor. And that is really contributing to even worsening of our healthcare disparities. So then you have this whole idea of food deserts, where you feel like there's not enough food for the poor people because it's not accessible. So the food desert, healthy food not being sold in local stores. I know when I moved to Louisville, they were calling it a food apartheid. Some people call it a food swamp because it's just poor quality food, but swamps are actually good things. So I'm not a fan of that term. But I understand what they're saying. And that's why I'm saying that they really are, that the word is misspelled. I'm saying that food deserts should be called food desserts, because that's what's happening. You have people going out and buying things because they're inexpensive for the reasons we talked about. And as long as the people prefer buying this kind of food, this is what's going to happen. Why? Because the stores, grocery stores, are not in the healthcare business. They're in this don't go out of business, and they will sell what people buy. So I'm saying the food deserts or food desserts are us. That is, if we haven't started in first grade or prenatal, getting people to understand a whole food plant-based diet is what they should be eating, then they're going to buy things that are ruining their health, and the stores are going to sell them. So don't blame the stores. We have to blame our own system. Okay. So I'm going to talk a little bit about what I think the answer is. Here's the guidelines, section 3.1. We talked about what does it actually say? Okay. Okay. We talked about not smoking, making sure you know with your cholesterol, getting it under control. Same thing with the blood pressure. Same thing with your blood sugar. Not using aspirin for primary prevention. Like we were saying in the past, we had that wrong for several decades. Physical activity, absolutely. People need to be doing more than 150 minutes a week for primary prevention, meaning you don't know that you have a disease, you don't have any disease, you haven't had a heart attack or anything. Excuse me. I always say secondary prevention, once you're managing a disease, you really should be at 300 minutes a week. But diet is that lower left-hand corner, more emphasis on vegetables and fruits and nuts. And this concept is so important. Here are the actual guidelines: more fruits and fruits, vegetables, nuts, seeds, whole grains. Fish, I know I took a lot of hits from my vegan colleagues about this, but fish swam into my guidelines. They were literally forced down my throat by the American Heart Association. Why? Because randomized trials show that fish compared to red meat lowers stroke, doesn't lower heart attack rates, doesn't lower cardiovascular death or overall mortality, at least not in the Predimed trial. But it did lower stroke. And unlike the American College of Cardiology, American Heart Association is a stroke organization. Okay, so that's the explanation of why you see that there. I wouldn't normally, left to my own devices, have any animal product in any guideline that I wrote. So anyway, getting rid of saturated fat, getting rid of cholesterol, sodium, and getting rid of processed red meat, refined carbohydrates, sweetened beverages are all actually very important. Now, what happens in terms of health equity if you actually improve the diet of the people who are at risk? We actually have that data. It came from Loma Linda almost a decade ago, where Gary Fraser actually tried to answer that question. We'll take the cross-section analysis of Black people in the Seventh-day Adventists. And what he found is that if they were doing a vegan or vegetarian diet, there was a 56% decrease in hypertension. Look at this, the diabetes, high cholesterol, all of it dramatically reduced. Now, the interesting part is that for the people eating fish, the so-called pesco-vegetarians, you didn't see substantial differences in the cardiovascular risk. And that goes along with the Predimed trial that showed no difference in heart attack, no difference in overall mortality or cardiac mortality, only a difference in stroke. And so you could actually do an intervention, and we actually did that on the south side of Chicago. I was fortunate to partner with Terry Mason, who many of you know, who's been out there pushing for plant-based diet for a long time. And he is one of the health ministers in this church. It happened to be President Obama's old church on the south side. And we actually did a study where we asked people to come in, get their risk factors drawn, and then volunteer to have free food, whole food, plant-based diet for 5 weeks, and then come back and have your blood tested again. And we did it over Lent, simply because, and not when I was a kid in the Baptist church, but Lent was a Catholic thing back then, but now it's pretty much everywhere. And it turns out that that African Americans on the south side of Chicago usually give up something for Lent. And so we asked them to give up animal products and eat the free food. It seemed like it would work. And then write down if they weren't able to comply with it. So what do we find? We found a dramatic, if you look in the middle red section, all those names of things, they're all cardiovascular risk factors that you can measure in the blood, and they all dramatically improved. This is what it looked like. The big ones that everybody should know about are insulin dropping. How does that happen? Because their weight went down. When their weight went down, their blood sugar went down. When their blood sugar went down and their weight went down, then their blood pressure went down. And so some of these results are mitigated by the fact that people came off of their drugs. And so they were doing so much better. Then the other one, that 4-letter word, please write that one down if you're not familiar with it, TMAO, trimethylamine N oxide. That is actually a metabolite of animal products. So of course it went down dramatically, but it also is coated by the microbiome, that is the bacteria in your GI tract. And so we were able to lower a huge amount of risk in the African-American community in that church. Completion rate was high, adherence was very high, and people lost a lot of their risk. And this is what can happen to our entire society. We don't have to actually stop here. So I would say that we have an opportunity to eliminate our healthcare disparities, just like we did with smallpox and yellow fever, with polio, with HIV, and now with COVID. We have the proof of what we need to do. all we need to do is actually do it. We eliminate the disease and the healthcare disparity disappears. So I would, at this point, I'll stop here just to say that in the end of this, the statistical analysis, we did put people back into their 10-year risk evaluation, and 19% of that 21% increase that's been hovering over the Black community, 19% of that risk was eliminated. Okay, so I'm going to stop sharing right there and open it up for questions.
Thank you very much, Dr. Williams, for that very informative presentation. So I just want to go over a few things with regard to for the Q&A so that everybody understands exactly how we do it. So we do not take questions directly from the chat. What we do is we ask everyone to raise their hand. If you're not familiar how to do that, you go to the button second from the right at the bottom of the Zoom window called Reactions. You click on that, and then you click on the raise hand function. I will, when I call on you, I will unmute you and ask you to state where you're from and to ask your question. And we just ask that all questions are brief and on topic. So with that, we're gonna go ahead and open it up to Steve. Please state where you're from and ask your question.
Steve from Rockaway. Good morning, Dr. Williams. Thank you so much. Nice to see you again.
Good morning.
That troubling information about fish and preventing stroke. Is there data about increased problems from the toxins that are accumulated in fish, as far as, I don't know, liver cancer or pancreatic or brain problems or any other parts in the body? It's, you know, it seems like the recommendations twisted your arm to approve it based on a reduction in stroke. And there are a lot of other things going on. That's my question.
Very well said. And I would say I would just add to your list. I'm really bad at actresses' names. The one who was in Titanic.
I know it. Kate
Winslet. Kate Winslet. Thank you. If you Google her name, you'll see that there was somewhere around the middle of last year, there was a documentary that she narrated, and she may have produced it or something. Somebody must have had, it was just so very well done. And they are showing it for free. You don't have to buy it. Everyone should look at that. If they think that pesco-vegetarian is a good idea, it turns out that you could have a really good discussion about which is worse for the planet. Eating cows and raising pigs versus taking fish out of the ocean. And so they do point out the chemical issues and the infection issues, disease spreading, no question that there are a lot more than just cardiovascular disease, and particularly cerebrovascular disease at issue when you're talking about replacing red meat with fish. So I'm sure the cows liked that recommendation, but from the other point of view, whole food plant-based would be better. So, and this is a big deal if I could talk about it for another 30 seconds or so, because we have so many people who have misinterpreted the Mediterranean diet data. They think that a Mediterranean diet is good. And I get into this fight sort of verbally with my friends and colleagues in cardiology, recommending a Mediterranean diet. Still not good for the planet. But if you just look at the basics of cardiovascular disease, what you end up with is three different things that you must control, okay? Cholesterol, inflammation, and TMAO. Now, there are some fish that actually have TMAO, but eating TMAO and developing TMAO in your own microbiome in your GI tract seem to be different things, okay? But there are no, I hate to say something gross, but carcasses of deceased animals that you can eat without increasing your LDL cholesterol and your inflammation level measured by high sensitivity C-reactive protein. And if you look at the data from Paul Ritker, published just a couple months ago in Lancet, lowering inflammation is a completely missed opportunity in cardiology. And he's talking about colchicine and methotrexate and canakinumab and all these different ways of lowering CRP. I'm just saying, whole food plant-based diet. David Jenkins published that with Portfolio Diet in 2003. And Benita Shah had a great randomized trial, Evade CAD, done at NYU, showing you want to lower CRP, you cut the animal products out, do a whole food plant-based diet. So anyway, I would say that I could argue very long and hard about not eating fish. But if you want to talk about eating cows versus eating fish, there are some advantages, not much, and not as a cardiologist. I'd say much more if I was a neurologist, I'd be a little more excited about it.
So on that topic, can you just describe how you were, I don't know if this was your word, so it may not have been, how you were forced to have fish in your recommendation?
Oh, so yeah, it's really easy. So when you're on a guideline committee, okay, first thing you do is everybody gets their own assignment. Of course, they gave me nutrition, all right? And so you're supposed to review from that point on all of the world's literature. You have in the hypertension guidelines, we use Dr. Evidence. We used a different company this time, but this is kind of what I do. So I had most of the evidence already. And then you put together what your recommendations are. And then most important point, when you walk into the room with your recommendations, you drop your ego at the door because you're going to take a pummeling. Okay. And each one of when people say that these guidelines are wrong, I can tell you these guidelines are very, very carefully done. And so when I come in there with my colleagues, like, Dr. Esselstyn, they will say, or Dean Ornish, Esselstyn was not randomized. Ornish was randomized, but it was small. If it's not a study with at least 50 people in each group, the Institute of Medicine says you can't use that to make a recommendation. I can quote it in the summary below, which I did, okay, that there's a lot of evidence that doesn't make it to the level where you can use it to make a specific recommendation. But here's the evidence. And the fact is very clear that fish compared to red meat decreases stroke, at least in that one trial. Now, you could argue with it that there is a Harvard publication from Nurses Health and the Health Professional Follow-Up Study where they said red meat kills, processed red meat kills faster. Here's the difference in mortality if you just replace the red meat with blank. And all of the blanks were on the left side. That is, poultry was better, legumes were better, soy was the best. Fish actually was 6% higher, didn't reach statistical significance, but in that particular data set, which is doctors and nurses followed for 30 years, fish actually had a trend toward increasing mortality compared to red meat. So I don't want to give fish a pass at all. And then I saw that documentary where I was talking about I would never eat a fish, but it's so easy for me. I'm allergic to fish. So if you want to see my face swell up, try a white fish.
Okay, thank you for that. And do people who eating a whole food plant-based diet still have heart attacks and strokes? And if so, why is that?
So it's interesting. People on a whole food plant-based diet. The question is, life or not? And number one, and if there's one you'll hear Gene Braunwald at Harvard talk about, it's the lifelong exposure to LDL cholesterol. And, his colleague, Paul Rickard, would say, well, don't forget about the inflammation. And then the people at Cleveland Clinic will say, don't forget about the TMAO. Okay. But his point is well taken. If people start eating an animal product diet in utero, meaning that their mother is eating it, okay, and then they continue that until they, something happens to their LDL cholesterol at a cardiology meeting at age 47, and they realize, oh my gosh, I should be vegan, which is what happened to me. Well, that area under my lifetime curve was suddenly improved, but I still had a lifetime of exposure. And, very few people know much about my personal story, but I basically grew up on the South Side, and I did mention having to move every year because we were poor. Well, we got even poorer when my mom went back to school, quit her job and went back to school. Then, the food stamps and we're not running. I mean, this was terrible. But one thing she learned by going back to school, she had a professor who said, if you eat meat, you're going to die faster. And so she came home and made us vegetarians. Well, except that the vegetarians, were still eating dairy and didn't realize that the cholesterol differences were not that much. And then, of course, growing up, becoming a cardiologist, I'm paying attention to the American Heart Association diet. So I was eating chicken and fish, no skin, not fried, not realizing that the inflammation and the LDL were just the same as red meat. I'm sure my colon cancer risk plummeted when I started that. But cardiovascular disease, I was still at risk and didn't know it. But then none of the stuff I've been talking about today wasn't published back then. So bottom line is that there really are no safe animal products for human consumption. And that's a hard truth for people to realize. But if you look at the Harvard data on risk, cardiovascular risk, cancer risk, overall mortality, they're all different. And fish and poultry are safer than dairy, which is safer than red meat, which is safer than eggs, which is safer than processed red meat. But there are no safe animal products.
So to follow up on something that you just said, that how long would it take for a person who comes to become whole food plant-based later in life until they have the same health outcomes as somebody who's been lifelong, or is that impossible to achieve? Hopefully.
Right. So your point's well taken. That is, you're lowering risk. And what you have is not elimination of disease, but you have mitigation of disease, and you have an improvement in your life expectancy. So I really don't want to minimize the fact that everybody needs to change today because they're going to benefit down the road. But when people say that, tennis, being a tennis player is 17 years longer life expectancy, and the trial says 15 years for vegan diet, they're really talking about lifetime exposure to sport and diet, so lifestyle issues. Okay. Can you come in as and start playing tennis at a 60-year-old and expect that you're going to get the same, 17 years? Probably not, but you're going to get some of it. And, it's hard to quantitate to exactly give you an answer, but I would say the thing to do, if you consider, everything from the planet, which we didn't talk too much about, animal rights, which we didn't talk about at all, and human health, we also just start today, and you're going to get some benefit. And yeah, I could still, I did my 20th year anniversary. There is actually a website, if you haven't seen it, where you could actually put in the search engine, your vegan calculator. I think it actually is called the vegan calculator. And it talked about the hundreds of thousands of gallons of water and the number of lives of animals I've saved. It gives you all the list of things that you've done for the planet by becoming a vegan and over a 20-year period. But I still expect that I could get cardiovascular disease, but it would be a whole lot later than it would have been if I hadn't made that change 20 years ago.
Great. Thank you. Our next question comes from Alex. Alex, please tell where you're from and ask your question.
Hi, doctor. This is Alex from California. Thank you for the great presentation. I have a question. If you had a patient that made a calcium score a few years ago and get, bad result like the 200, 300 number, and he changed his lifestyles, moved to a plant-based diet, exercise, do everything based on the recommendation, everything the right way, would you recommend him to take another calcium score to check if the risk been reduced or the situation been improved, or would you recommend to do any other type of test just to check if the situation become better than the previous test? Thank you.
So, so you didn't mention spending much time in Great Britain, which would have made it an easier answer, because the National Institute, they call it NICE, has come down on the side of using coronary CT angiography. It is not adopted at that widespread sort of in fact, we really argue to get it paid for. Medicare pays for it, but a lot of the insurance companies want to restrict the use of CT angiography. It's basically like a cardiac catheterization without the catheterization. You get the pictures of the artery. It's better than a cardiac catheterization in that the X-ray dye is the same, but the X-rays are not. That is, when you get a coronary angiogram, you basically are seeing what's on the inside of the artery, and you can see, oh, there's a 90% narrowing in your proximal left anterior descending, the widowmaker. This is so, you can see that, but you don't see anything about the plaque itself. As opposed to a CT angiogram, you actually can characterize, is it fatty plaque? Is it fibrofatty, which means it's starting to heal up a little bit? Is it fibrous, which means it's pretty much stable? Is it fibrocalcific, meaning it's starting to harden, or is it calcific, which is it's really stable. It's rock hard, literally rock hard, okay? Well, it turns out that calcified plaque does not give you heart attacks, or if it's in a carotid, it's not going to break off and give you a stroke. It's the unstable plaque, which is the fatty and maybe fibrofatty. So this is the vulnerable plaque that you want to get rid of. So when you say you've done everything well, we're hopefully talking about a whole food plant-based diet and statin or whatever you can do to lower both inflammation and cholesterol so that you start reabsorbing the LDL out of the plaque, okay? And everybody has seen Dean Ornish's stuff on plaque regression, Caldwell-Esselstyn stuff. There's also, it's Ornish, Esselstyn, high-dose rosuvastatin, high-dose atorvastatin, and evolocumab. There's 5 things that are out there on the market that can be done to reduce plaque. And you're not reducing the calcified plaque. If anything, the calcified plaque goes up, okay? That is why, because you're taking dangerous plaque that can give you a heart attack and turning it into rock hard plaque that will never give you a heart attack. And so some of it absorbs, some of it heals. Healing is, getting the calcium deposits. So that kind of answers your question. That is, if you have a calcium score of 200, you're already in the area where you should be on what we call antiplatelet therapy. That classically was aspirin. It may not be the best. The more recent trial, which was presented but not a full publication yet, so I can quote it and you can look it up. It's called the Panther trial, that says that when we were always, a person with a heart attack gets two antiplatelet drugs, aspirin and then something else, typically clopidogrel, that's trade name Plavix, or Brilinta, or prasugrel, one of those 3. And then over time, depending on what their situation is, with a heart attack, it would be at 12 months, you would drop the others and keep the aspirin at low dose. Well, it turns out the Panther trial says we had it wrong, that aspirin gives more intracranial bleeding and more GI bleeding. And so we should be using the others. They're a little more expensive, but not that much more, not like a GI bleed expensive. So whatever the antiplatelet therapy is that your doctor chooses, that's what you should be on, plus a statin, unless you can get that LDL down other ways. And you'd have to be lowering both your C-reactive protein and your LDL to get the effect that you want. And so that's usually done. Anything with a calcium score greater than 100, we recommend the statin and the aspirin or antiplatelet therapy. If it's below 100, not worth the aspirin, we need to go back and look at the others and say maybe it is worth doing those, but we don't have the data. And if it's calcium score of 0, even if you have like a 25 or 30% risk, and some people do, have a calcium score that's 0 with ridiculously high risk factors. If you're one of those people, you don't need either.
So just to clarify, because he'd asked about getting a second calcium score test to see where he's at. Does that calcium score ever would that ever get lower? Or is that once you have a calcium score at a certain rate and the calcium has hardened, it's going to stay that way regardless of what you do?
Thanks. You called me out. That is, I gave such a long, detailed explanation that the answer probably kind of what I was saying there is that number one, the calcium is your friend.
Mm-hmm.
Okay? That's your goal, is to get it all to calcify. And so the best way to get it to calcify is a statin. Okay, so you put people on statin, their calcium score goes up. Now, you could also see the score go up when the disease is getting worse. Okay, so so that's telling you that doing a second scan is really not helpful. The time when it's helpful is when it's 0 and a person is at risk, repeating it at 5 to 10 years, or if it's less than 100, because we're still not recommending antiplatelet drugs for less than 100, such as aspirin. And so repeating that one in 5 years would be a good idea to see if you're now above the threshold where it changes you from statin only to statin plus aspirin, or whatever the antiplatelet drug is for the next generation.
Great. Thank you for that clarification. So, a lot of people in this audience are eating whole food, plant-based diets and are exercising and maintaining a healthy weight. Do those people need to be concerned with going and getting these various tests if they've been doing this for a while and they feel good? Is that something that they should be looking into, getting these various tests, or are they pretty much doing the right thing and therefore don't need to worry about to be so proactive, I guess, in getting these tests with regard to heart disease and stroke, for that matter? So
as you know, what I'm going to say. So why is this guy picking up his phone? Because I got to show you this. Okay, I put that on the screen. Okay,
Mm-hmm.
This is the American College of Cardiology A calculator. So you saw that on my slide with the African American Church, that 19% decrease in their overall risk.
Yeah.
Okay. This is how you do it. Everyone should have this on their phone. So every time, this is Mother's Day, somebody's going to have a dinner. You'll see Uncle Joe. Uncle Joe, how old are you? Okay, so you're male and you're Caucasian. And what was your last blood pressure? And what was your last cholesterol? Just give me a ballpark. And do you remember your HDL and your LDL? And you're not a diabetic, and you quit smoking 10 years ago, and you put all that stuff in there, and it'll tell you the 10-year risk of having heart attack, stroke, or death. Okay, that should tell you whether or not you need all these tests. And that is, if a person has a 0 coronary calcium score, then they don't need the therapy that the recommendations otherwise would say. If you have a risk of less than 5%, 10-year risk, you don't need a test. If you're between 5 and 7.5, there's a whole bunch of things, like 14 different things. Do you have lupus, rheumatoid arthritis, any chronic kidney disease, any family history of somebody dying of heart disease below age 60, premature coronary disease, any inflammation, and that you can measure that with your C-reactive protein. Do you have one of those fancy lipid tests that says that you have an elevated Lp(a), or anything that would be genetically putting you at more risk than the usual population? Then at 5%, you start doing the coronary calcium test. If you don't have one of those many things I just mentioned, which most people don't, then at 7.5%, you start to say, you really should have this test. If you get above 20%, you might want the test out of curiosity, but even if it's negative, you still worry. Why? Because there is such a thing, as I've been talking about, as non-calcified plaque. So there are people that test a 0 calcium score isn't perfect. It's darn good. And they call it the power of 0, but the power of 0 isn't cardiac mortality for the next 10 years. It's just extremely, extremely low risk, like 6 events out of 1,000. So it was 0.06% or 0.6%. That's pretty low, but it's not 0.
And where can we find that calculator?
Oh, just put it in your search engine. You can find it immediately. So ACC risk calculator. The official name is a little harder for people. 100% of people get it wrong when I say it out loud. So ASCVD, and then they'll say, what? So those 5 letters, ASCVD, that stands for atherosclerotic cardiovascular disease. Okay. But if you put in there ASCVD risk, it'll pop up.
All right,
it's free.
Perfect. Thank you. And do higher levels of cholesterol lead to higher levels of heart attacks and strokes? And what do we do if your cholesterol level is high, but you already eat a whole food plant-based diet?
So we're talking about the genetics, and as I mentioned before, we were talking to. So the person putting that in probably was right before I made the comment about lifelong exposure to LDL cholesterol. So yes, having a high cholesterol, and it's so funny. As a friend of mine showed me an article. I think it was in AARP or something. That said, "Oh, the cholesterol myth." That people are saying that elevated cholesterol is bad, and it's not true. Well, and then when you read their bullet points, they were all proving the opposite. That is, they were saying your total cholesterol is not important. That is true. It's your LDL cholesterol, and they're saying, but the LDL isn't as important as people say it is. It's your small dense LDL. That is true. Everything they said is true, which meant that whole title of cholesterol not being important was completely misleading because all the data they were talking about was emphasizing the importance of having a low LDL, particularly small dense LDL. How do you do that? Get rid of your triglycerides. Okay. How do you get rid of triglycerides? A whole food plant-based diet plus exercise. And if your triglyceride level is double digits, your LDL is less dangerous. Okay. So people can actually benefit from lifestyle more than they think if they can get the LDL down and protect themselves from the real dense LDL. There are people genetically who have a high LP(a). Have to be mentioned that it's a significant portion of the population, a good 10%. And if you have one of those genes that makes a high LP(a), then you really should realize that you are at more risk than even the risk calculator will tell you. And so you take that risk seriously if you have LP(a). People will tell you that it doesn't respond to diet because it's completely genetic. But if people who saw that slide, 5-week intervention in our African-American community, LP(a) dropped, just like everything else dropped.
Great. Thank you. Our next question is coming from Dorothy. Please state where you're from and ask your question.
Yeah, hi, good morning. I'm Dorothy. I'm from Long Island in New York. And first, I want to thank you for doing these lectures because I find them very helpful. So thanks for doing that. My question is about lowering LDL cholesterol. And I seem to remember from one of your previous lectures, and maybe I got this wrong, so I thought I'd ask. But is there data that shows that goji berries are helpful in lowering cholesterol?
So I've actually never had it on a slide, but it comes up a lot in the discussion portion, and that is non-statin therapies that are nutraceuticals. And yeah, if you put that in your search engine, you will find that there's a small amount of literature on goji berries, bergamot, berberine, amla, that's in Indian gooseberries. And the question is, how good are they? Well, so first of all, as a journal editor, I'm always sensitive to the whole idea of positive publication bias. If somebody studies something 10 times or 10 different groups, study the same thing and 9 of them don't find anything and the 10th one does, that 10th one is the one that's going to submit for a publication. And it'll get past the reviewers and past the editors, and people will not know that 9 times out of 10, it doesn't work. So why bring it up? Because I was so into nutraceuticals, both personally and professionally. And what I saw is minimal changes. And so I had to worry about this positive publication bias, not to put any of them down, but what we really want is good outcomes. The only one that I've seen that actually had cardiovascular outcomes with it was red yeast rice, which is one that I personally would never use. Why? Because it's lovastatin. And lovastatin, the trade name was Mevacor. It was like our first statin. It's fairly weak. And compared to the other two, atorvastatin, that actually have plaque regression data, I mean, if I'm going to take a statin, take a real statin, and one that has a lot of evidence behind it in terms of plaque regression and great outcomes, as opposed to a little bit of statin that you don't know. You don't know how much statin you're getting necessarily, because it's not FDA controlled. It is a natural product. And Merck sued them to try to get them to stop marketing their drug. Well, it's not their drug. It's just chemically is the same, okay? But it's not their drug. It's a fungus, red yeast rice, that produces a chemical that is essentially the same and has the effects, but the effects are small. And you don't know how much you're getting. Is it 3 milligrams? Is it 30 milligrams? You don't know. So bottom line is that there was a review article. I was actually trying to do it with Michelle and a couple of co-investigators. And right when we were collecting all the data, with fears about publication bias, positive publication bias, turns out that someone else published it. These compared to statins just aren't very good at lowering LDL. And so I'm just waiting for more data with outcomes. If you don't have outcomes, just changing the biochemistry doesn't make me nearly as comfortable.
Just a quick follow-up on that. You talk about nutraceuticals. What about the actual, powders from the plants? Michael Greger does a video, has multiple videos on the effects of AMLA on various. I think we just lost your camera. There we go. On various issues in such as cholesterol. Showing that it according to the research he was reviewing, that it does have a very significant effect on cholesterol. Yep. That wasn't some company putting it into a pill form. It was really just the powders and a very small amount of the powder. Do you find that the same? Have you looked at that research?
So this is exactly what I'm talking about. When we stopped looking at it, which was probably when I took over as chair of medicine, there were 22 of them on our list. I mean, it was garlic, it was dried onions. There were so many things that were on that list where, in order to get on my list, you had to have a randomized trial showing an improvement in some biochemical marker, particularly LDL cholesterol. They all had the data, but looking for what you want is not just a change in the biochemistry, but you want change in outcomes. So if Dr. Greger or anyone has AMLA showing a decrease in heart attack, stroke, and death, I haven't seen it yet, and hopefully it will be published. And I would love to see that publication. So someone can throw it in the chat if they've seen it, and I would be more than happy to change my tune on it. Because I still give people the list if they're interested in it, because I believe that LDL lowering by any means necessary, any beans necessary, any greens necessary, is good, basically. But if you press me to the wall and say, how do I know that newest drug, inclisiran, which you only have to inject twice a year, okay, how do I know that it lowers, I know it lowers LDL cholesterol, or else it wouldn't have gotten FDA approved. How do I know it lowers heart attack, stroke, and death as good as a statin? I don't have that 5-year data yet. It just came out, okay? But we do have the data for evolocumab and the two of, and alirocumab and evolocumab, because they've been out since around 2013. They were really expensive, and then they're better. They're not twice a year, they're twice a month. And, they're 60% lowering in LDL cholesterol with an injection, and you don't have to take statins. Great. But how do we know that it works just as well? Well, at this point, we do have data you worry about it because statins lower inflammation. Whole food plant-based diet lowers inflammation. The evolocumab and alirocumab do not, but they lower LP little a. Okay. So you put all that together and they do have good outcomes. So anyway, I would say that what I'm hoping to see is some nutraceutical or combination of them. I mean, you got 22 of them, that's 22 to the 21st power of combinations that you could do. Okay. Excuse me. And it would be great to study and see which combination of drugs would actually give you outcomes as good as the pharmaceutical industry and not have to do drugs. It would be great. But right now, I don't see that we have that data.
Thank you. Can everyone achieve a healthy weight through diet and lifestyle, or are some people not able to do it due to genetics?
Really important principles about weight. Number one, like almost everything in cardiovascular arena, hypertension, diabetes, high cholesterol, it's your microbiome. That is, it's the bacteria in your GI tract. They're bad when you eat animals. They're good when you eat a whole food plant-based diet that's fiber filled, okay? You could take the microbiome that is a fecal transplant. You could take the stool of a thin person, give it to an obese person, and they'll lose weight. You could reverse it, and the thin person would gain weight, okay? So it's all about the microbiome. Now, having said that, there are some genetics behind weight, but most of it is determined by not just metabolism, but calorie intake. So the most deadly diet that we've seen in cardiovascular medicine is the keto diet, where people eat just animal products pretty much all the time. A lot of butter, a lot of eggs, red meat, and the like. And you see an increase in inflammation and LDL. While their weight goes down dramatically, their diabetes is cured, their hypertension gets better. Why? Because of obesity, particularly central obesity, going down. Yet they have heart attacks. Why? Because of the LDL and the inflammation, okay? And the TMAO. The keto diet raises all three, okay? And so the answer is that if there is no person who is, malnourished and starving, who's actually, chronically, acutely, yes, but not chronically, who's actually overweight. By definition. So if people are saying, well, I can't get rid of the weight, it's because you weren't the hockey player that got checked into the boards and broke your jaw and you're drinking through a straw and your caloric intake drops, okay? Or the person who tried intermittent fasting, which we thought was so great because it was going to change, how your endocrine system worked with your caloric intake. Eat while your cortisol levels are high and you metabolize it better. No, it turns out that wasn't a mechanism at all. It was the time restricted eating was restricted eating. So people didn't eat as many calories, and it actually works. So the key is change the microbiome with a whole food plant-based diet so you can control what you're absorbing. And that's number one. And number two, eat less calories than you're burning. And if you do that, your weight will go down.
Thank you. Next question from Jay. Please state where you're from and ask your question.
Hi, my name's Jay. I'm from the UK. I was just reading up about a fatty liver disease, non-alcoholic fatty liver disease. What test would you recommend for that, and what symptoms would one have for if you've got the condition of fatty liver?
So you're going to get me in a little trouble with home. That is, I have an amazing amount of basic science research and clinical science in GI working for me at University of Louisville, who are dedicated to the FibroScan ultrasound. That is the test that they're recommending. So the trouble starts that I really am a CT doc, and if somebody had a CT, I look at every aspect of it because it gives me so much insight into heart size, coronary, how big is the aorta, how thick is the muscle, and guess what else is in that chest CT? The liver. And so what I'm trying to get everyone to do is to read out when there's fatty liver on the CT because CT has done so much more than FibroScan. So anyway, I may not be able to, I don't have data on comparison yet. I'm hoping to work with our folks to answer your question. But I would say that right now, FibroScan would be the state of the art. Okay, it'll actually give you a score. But I'm thinking that CT scan is going to be an awfully good one. Either way, what you really do want to do is manage it. And that was that previous question about obesity. If people are doing a whole food plant-based diet, improving their microbiome, decreasing their calories, they will reabsorb that fatty liver before it becomes scar tissue and shows up on a fibroscan.
Thank you so much.
Thank you.
So, what measurements do you consider most accurate to gauge health? Blood sugar, weight, cholesterol, blood pressure, and could you offer number ranges for those that you would consider most important in evaluating someone's health?
I'm going to go back to the risk calculator. That is, there are people whose LDL cholesterol is high. I was one of them. And yet, I didn't go out and get a calcium score because once I went vegan, my blood pressure, African-American male over 60, blood pressure went to 104. Okay. And if you put all of those things in the risk calculator, I was always less than 7.5%. Well, so what it's really saying is that they're all very important. And I would say that the best way to assess risk isn't by picking out one of them, but to put them, amalgamate them and compare them with large data sets, which is what that risk calculator is. It's the so-called pooled cohort equation, where you have large cohorts of outcomes and risk. And you'll see that being Black is bad, and being over 60 is bad, and being male compared to female is bad. But having a high LDL cholesterol and a high blood pressure in a smoking diabetic, you're off the charts in terms of risk. So put it in the calculator and see where you are. I'm going to have to plug in.
Yeah, no, you take care of what you got to take care of.
Okay, I'm back.
All right. And another question for you here is, what supplements, you're talking about nutraceuticals, so this might be the same thing. Are there any supplements that that you suggest, whether on a whole food plant-based diet or for the general population? And what are your thoughts on CoQ10?
So the most important thing about CoQ10 is that I've never seen it improve anyone's cardiovascular outcomes. The real issue is that there are some people who are statin intolerant, and statins are probably the best thing that we have in cardiology. And if taking that CoQ10 expensive supplement will let you take that drug, then good for you. Then that's fantastic. All right. But other than that, I haven't seen any outcome studies that say that it actually does any benefit. And dropping your CoQ10 level, which statins do, doesn't seem to harm anyone. So love to have some randomized trial evidence showing that CoQ10 actually did something positive, and that would be great. Other supplements, the most important one is B12. And you'll hear this a lot, and I hope that everyone has that solidly in their mind, that, the meat eaters are no longer absolved from getting low B12. Why? Because they're eating a lot of animals that are factory farmed and never get out and graze. What am I talking about? Well, the B12 comes from the bacteria in the soil. So you either have to eat dirt, like eat dirty plants or eat dirt, or eat an animal that ate dirt, or take a B12 supplement. That's easy choice for me. I just take, if you're going to eat dirt, know what Clostridia kind of organisms you're going to be eating. So I probably would avoid that. And I'm certainly not going to take a life of an animal so that I can get B12.
Great. Thank you. Our next question is coming from Bin Wu. Please state where you're from and ask your question.
Hello, thank you very much for the time to share with us. And I got one question, because you said all is come from the bacteria in the gut, and we can changing the gut bacteria by the food. Besides this, do you recommend everyone take the prebiotic? And if we take this prebiotic, how long should we keep to take?
So you saw my eyes light up when you said prebiotic, because prebiotic actually means changing your diet to a whole food plant-based diet. I think you were asking me about probiotics.
Yeah, probiotic. Yeah,
Okay.
probiotic. I'm sorry.
Probiotics, these pills that
It's bacteria.
my friends are pushing, the data is lacking. Now, when you think about the science of it, it has to work. It just hasn't worked yet, that I can see. Now, I haven't checked in the last week or two, but what we're looking for again is a randomized trial with the probiotic that gets through the gastric acidity. That is, when you take a pill of bacteria, most of them are going to get killed by your stomach, unless you have some kind of preparation that'll get through the stomach and get into the small intestine and preferably into the large intestine and change the population. And so in theory, why do I think it works or should work? Because fecal transplant works. And so if somebody has Clostridia difficile, a spousal fecal transplant can get rid of that disease for them. So you certainly can change, and a whole food plant-based diet works to change your microbiome. How long does it take to change your microbiome? A couple weeks. And this is something that I think we should be focusing on it a whole lot more. I didn't show you the COVID data, but you might want to, put that in your search engine. The serious COVID is caused by having bad bacteria in your GI tract, creating inflammation, so-called cytokine storm. And people who are plant-based have a better microbiome and had a better time of COVID. I keep, hearing that no vegans died of COVID. I don't know that that's really true, but I know of a vegan that died of COVID. And there certainly was the Sarah Seidelman article saying that the odds of a person who was on a whole food plant-based diet getting serious COVID was dramatically reduced, 73% dramatically reduced in 6 countries of data that was put together. And pesco vegetarian was down about 53%. And it was I think a 54% increase in severity of illness if you were doing a keto diet, because that's a diet, the amount of bad bacteria you have. You can't eat decaying flesh and not ruin your microbiome.
So to go along with the probiotics, you're saying that the probiotics, the research really isn't in yet on whether or not they work, or you haven't seen anything. What about fermented food?
A little. That is, the research is in it. It says that they don't work, and I'm saying we just haven't gotten there yet. But the ones that are being sold right now, I challenge anyone to show an outcome study saying that it actually improves something. I really, because I think everything is about the microbiome. This has to happen. So please, if anybody has any information on one being positive, I'd love to know.
What about fermented foods in order to get probiotics into your body?
Same idea. That is, and I don't do them because I don't like them, not because I don't drink alcohol. Anything that's fermented, it's just not good for me. But that's a per taste, and it's I changed my taste based on outcome studies. And so all of a sudden, those greasy little green things called avocados, I love them. Why? Because simultaneously, a few months ago, there was an article on increased life expectancy and decreased LDL. All of a sudden, they taste good. There's something bizarre in my brain. I understand that. That is good. That cardiac outcomes changes my taste buds. But I haven't seen it for the fermented stuff, and I haven't seen it for probiotics. Still waiting for it.
Great, thank you. Our next question comes from Dorothy, and we have just so you know, we have about 2 minutes to get the question out and have it answered for the end of the Q&A.
Okay.
Dorothy, stay where you're from. That's the question.
Thank you. Dorothy from New York again. Just a question about this microbiome. I always understood that yogurt and kefir were good for your microbiome, but I know they're dairy products, and yes, I do eat them. But is there any truth in that? And I know you're recommending no dairy products, so are like the non-dairy based yogurts good for microbiome?
So, curious answer. I would go on the side of the non-dairy yogurts, on the hope that the microbiome would improve with with that. I still haven't seen a good randomized trial where they isolated that was the active agent that made things better. But the problem with the plant-based yogurts and with some of the dairy yogurts is you got to flip it over and look at the sugar content. And the sugar to fiber content or sugar to fiber ratio, if it's more than about 4 to 1, that is like 20 grams of sugar, 5 grams of fiber. More than that, you may just be inducing a big insulin spike, which makes your cholesterol bad, increases inflammation, increases weight. So it would be nice if we had the kind of yogurt that was low in sugar. I just haven't seen them. So when I do the yogurt, which I used to make this all the time, I put a bunch of grains and nuts in it. And then it actually tastes better and it has the fiber to cover that added sugar. So I'm hoping that, and avoiding the saturated fat, some of the low fat yogurts, they have tiny amounts of cholesterol and tiny amounts of saturated fat. So then I don't want to do it mostly because of what happens to the cows.
Great. And with that, we conclude our Q&A. I want to thank you very much for that very informative presentation. We can open up the mics, please.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you. Thank you for your knowledge. Thank you for your knowledge. Thank